Welcome to the WebMD Health Discovered podcast. I'm Dr. Neha Bhatta, WebMD's Chief Physician Editor for Health and Lifestyle Medicine. What comes to mind when you hear the term menopause? Disruptive symptoms like hot flashes, mood swings, insomnia, and irregular periods? Menopause is a familiar term, and yet the actual intricacies around it often go undiscussed and are clouded with myths and misdiagnoses. Perimenopause is the phase of a woman's life that precedes menopause, typically starting in a woman's 40s, but sometimes even earlier. This is something that all women have experienced or will experience in their lifetime, but despite its prevalence and impact, perimenopause often flies under the radar in discussions about women's health. Misdiagnosis can be rampant, with symptoms too often being attributed to stress, aging, or even dismissed altogether. Why is such a significant phase of a woman's life so often overlooked? Is it the general taboo around discussions of women's health, a lack of understanding and open communication among both healthcare providers and the general public? Or maybe it's simply the broader tendency to sideline women's experiences in medical conversations. Here at WebMD Health Discovered, we have spent a lot of time talking about this topic in the last year. We decided to pull together 3 powerful episodes and bring you the most important pieces of information from each episode to offer a comprehensive understanding of this stage of life. Let me introduce my first guest, Dr. Sharon Malone. Dr. Malone brings decades of clinical and real-life experiences to her treatment of women in the menopausal transition and the post-reproductive years. She believes that all women should be able to make decisions regarding their health and quality of life based on facts, not fear. So let's start by having Dr. Malone answer the questions that are on so many of our minds. What is perimenopause? When does it occur? And how will we know when it begins?
Perimenopause is a little bit difficult for women to really put their finger on because it's not a bright line that signals when perimenopause begins. We almost back into the definition of perimenopause. We take the average age of menopause being about 51 and a half, and perimenopause, which is just the menopausal transition, can start anywhere from 4 to 10 years before you've had your last menstrual period. So perimenopause tends to sneak in before women are even thinking about menopause because it happens usually in your early to mid 40s. And the symptoms, my goodness, there are over 30 symptoms of perimenopause, not any of which that really need to go in any particular order. The first thing that women tend to experience is an irregularity of their menstrual cycle. At times, it's almost imperceptible. The cycles will get a little closer together than what you're used to. Instead of a 28-day cycle, it might be 24, 25 days. That's usually the first harbinger of things to come. And from that, you can get any combination thereof of hot flashes, mood swings, brain fog, changes in libido, changes in weight, dry skin, itchy skin. The list goes on and on. And because they don't happen in any particular order, a lot of women experience them in isolation and they aren't really thinking about it under the big rubric of perimenopause.
Dr. Malone covered a variety of perimenopause symptoms. But what if we're not experiencing these symptoms? Do we still have to talk about this topic with our doctor? How often are menopausal symptoms mistaken for another condition? Can we take a proactive approach? And what impact would that have on our experience with this transition?
Chances are, if you are in your early to mid 40s, just assume that you are in perimenopause because that transition has begun, whether you're having symptoms or not, because the range of symptoms varies from person to person. And some women are very, very, very bothered by this transition, and some have almost nothing. Rather than waiting for a symptom to define when you were in the menopausal transition, a good rule of thumb is to look, generally speaking, at your age. And if you're in your mid 40s, you're in perimenopause. The way I always approach this in my practice is that when women got to be in their late 30s, early 40s, we sort of have a preemptive conversation I explain to them what phase they're entering. We go through the symptoms that you may or may not have. And I think it's very comforting for patients when they start to get into this phase and maybe your symptom is brain fog or sleeplessness. Just knowing what it is somehow very comforting. We like to give patients anticipatory guidance such that they're not floundering around or thinking their weight gain requires that they go see an endocrinologist, or I'm depressed or anxious and I should see a psychiatrist. So it sets the tone, lays out what things can be, and whether or not to do anything about those symptoms. And I think this is a very important point, is whether or not you're bothered by them, because there is no right answer for every person. But every person understands when they find that whatever symptoms they are experiencing, be they bleeding, be they depression, sleeplessness, hot flashes, you know when it is getting in the way of your day to day functioning. And if and when that happens, then that is really the time to go to your provider and to say, hey, I need to do something about this, because there's no real benefit in suffering for years before you seek help. We need to have language. We need to have education about the process in and of itself. And that way we know what to do. We can't really seek help when we have no idea what we are experiencing. Or the other side of this is sometimes women do complain and they complain mightily to their doctors. So we've got an education gap on both sides. We need to educate women, but we also need to educate our doctors to say, once you've ruled out heart issues, those palpitations can be very much a sign of perimenopause or going through this menopausal transition.
Dr. Malone underscores a critical aspect regarding the gap in education between patients and healthcare providers. However, nowhere is confusion and contradictory information more prevalent than in discussions surrounding hormone replacement therapy, HRT, and what a lot of healthcare providers are transitioning to calling menopausal hormone therapy. On the WebMD Health Discovered podcast, we adhere to methodical approaches to healthcare, which becomes even more imperative when dispelling misconceptions. So, what are the prevailing myths circulating about hormone replacement therapy? Commonly, we hear that HRT leads to breast cancer or ovarian cancer, as well as heart issues or blood clots. But where did some of these misconceptions originate? And what are the actual facts around HRT? During the 1960s, hormone replacement therapy emerged as a revolutionary treatment for menopausal symptoms, representing a significant advancement in women's healthcare. By alleviating symptoms like hot flashes, vaginal dryness, HRT supplemented declining hormone levels, empowering women with greater control over their health and well being during this transitional phase of life. But in 2002, the Women's Health Initiative released preliminary findings from a study investigating estrogen and heart disease, causing reverberations throughout the medical community. The startling revelation was that HRT posed more risks than benefits for women, particularly postmenopausal women undergoing combination hormone therapy for menopausal symptoms, elevating the risks for breast cancer, heart disease, stroke, blood clots, and urinary incontinence. But the most crucial aspect of this narrative often receives much less attention. A reevaluation of the WHI trial revealed that HRT usage in younger or early postmenopausal women yielded positive effects on the cardiovascular system, mitigated coronary disease, and reduced overall mortality rates. Dr. Malone elucidates the advantages of both lifestyle modification and HRT in this context.
Hormone therapy, or using hormones to treat the symptoms of menopause, is certainly a viable option for women who are bothered by their symptoms. And once you have tried lifestyle things, try to get regular bedtime, exercise, minimize alcohol intake. If you smoke, don't smoke, because what we do know is that smokers have a more difficult time during menopause and have an earlier menopause than women who don't. So these are the lifestyle things that I'm talking about, not just, oh, here's a supplement, here's a herb, try this, try that, because
Right.
for the most part, they're not very effective at treating the symptoms of menopause. If you're going to have any effect whatsoever, let's start on the lifestyle front first, see where you are. And again, there's no virtue in suffering. Once you've tried that and you're not getting the relief that you need, you should seek help and get relief of your symptoms. I'm so glad that this conversation is happening more and more because we're able to help each other out as women. It helps to talk to someone else about this who has perhaps gone through it. And I don't think that anyone should feel ashamed or embarrassed or feel as if they do need help, that that's somehow a personal failing. It is not. It is just simply how your body is reacting to this hormonal fluctuation that is going on during the perimenopausal phase. And there will be another set of issues that happen once you are postmenopausal. I think it's vitally important that everyone try to start as best you can position of health. That means getting regular exercise. That means trying to eliminate as many processed foods as you can from your diet, more fruits, more vegetables, and then getting sleep. And I think that we're coming around to this more and more and more about how important sleep is, not only for cognition and mood, but also for decreasing our risk of cardiovascular disease. So those are the big three in terms of the lifestyle things you can do. And then beyond that, once you've done all you can do and you need treatment and you are still bothered by your symptoms, then that is the time when you should engage with your provider and explain to them, these are the things that I'm concerned about. This is affecting my quality of life. What is appropriate for me at this time? And I think that that is a conversation that we have got to have. And don't let your doctor discourage you because, as I said before, we have doctors that have not really kept up with current research and they're still looking backwards 20 years ago, the data from the Women's Health Initiative. And women are afraid of breast cancer. If I had to say what's the number one reason why women avoid taking hormone therapy, even when they are very symptomatic, it is that fear of breast cancer. And I think the message that women should get is that the risk of breast cancer pales in comparison to the other cardiovascular events and the other issues and perhaps osteoporosis. So you need to put that in perspective. But the risk was never large, but a bit overplayed. So don't let that be the reason why you don't explore getting treatment for yourself.
Our discussion on menopausal symptoms and possible treatments leads to a discussion about brain fog. Here to discuss this topic is Dr. Gayatri Devi, Director at Park Avenue Neurology, Clinical Professor of Neurology and Psychiatry at Zucker School of Medicine, Northwell Health, and attending physician at Lenox Hill Hospital. Dr. Devi opens her discussion with one of the best health discovery stories we've ever shared on this podcast.
I actually am trained in neurology and cognitive neurology, and that generally means taking care of patients with dementia. And about 25 years ago, I saw a patient at Columbia where I was a young faculty member who was in her 50s. And she came in with significant cognitive loss, inability to function. And we did a full evaluation on her, including a spinal tap. And after a consensus conference with a whole bunch of physicians, geriatricians, psychologists, et cetera, at the hospital, we decided that this woman likely suffered from Alzheimer's disease. And I sadly had to tell her that this was the case. And at that time, there was very few medications available to treat Alzheimer's. So I put her on the medication that was available, which was donepezil. But I also decided to add a little bit of estrogen because there had been a recent study that said that perhaps estrogen helps keep people with Alzheimer's out of nursing homes. So I thought, she's young, she's in her 50s, she has this condition. Let me put her on some estrogen. So I put her on estrogen. And then she came back about 6 months later and she said, I'm cured. All my symptoms are gone. And I thought to myself, well, clearly that can't be true. But in fact, when we did testing on her, we found that most of her deficits had resolved. And in fact, it was I who was mistaken that she didn't really have Alzheimer's, that her cognitive loss was related to menopause. And she had had a late life menopause. And that may be why she had had those symptoms. And giving her estrogen seemed to have cured her. And that's what started me on my quest of taking care of and trying to define the cognitive changes around menopause and perimenopause.
Hearing this, someone might wonder, why don't we put all women on estrogen therapy? And if we can't do that, is there a diagnostic tool available? And when should we have these discussions with our doctor? How do we know when it's the right time to have these discussions?
My research and the research of others supports evidence that up to 60% of women going through menopause across cultures around the world have cognitive impairment. They complain of memory problems. Actually, about the same percentage of women who complain of night sweats and hot flashes. So a significant number of women have cognitive loss. But you can't just put everybody on hormone replacement. There are some people who may have memory problems because they're not sleeping well because of the hot flashes, and there are side effects with any kind of medication. There's the risk of blood clots. You don't want to just, in a cavalier way, put people on something unless there's need for it. When you have estrogen loss, there's a reduction in what's called the dendritic spine density and synapse formation in the parts of the brains that are important for memory, like the hippocampus and the basal forebrain. And that, has been proven in animal studies. And in humans, when we're going through our 40s into our 50s, we have a decrement in synaptic density, and it may be accelerated by early menopause and early loss of estrogen. And then chemically, there's reduced acetylcholine and reduced serotonin in the brain at that time. And so this combination can exacerbate the cognitive loss that women notice. And just to tell you, it's not just that they notice the cognitive loss. If you do testing, there's objective evidence of cognitive loss. Just like in my patient that I mentioned earlier, enough so that sometimes it mimics something like Alzheimer's, even though it's not. And then the high levels of cortisol that happen during hot flashes, that also can worsen memory. So there's a bunch of different reasons where low estrogen can impair optimal functioning in the hippocampus and brain regions and other brain regions that are responsible for learning and for registering and retrieving new information and for language and executive function. Generally, you cannot do what's called a mini mental status exam or a Montreal cognitive assessment, which are simple screening tools to look for cognitive problems. Because menopausal women, especially the ones that I see in my office, are usually very, very highly functioning women who reached like the peak of their careers because of their ability to articulate, because of their ability to convey their thoughts into sentences that are then actionable. So when you suddenly find that you're struggling for words, when you suddenly find that you cannot multitask, something that you prided yourself on, when you find that you can't really hold conversation or hold the thread of an idea long enough to be able to express it, it's very disconcerting. The kind of testing can't just be simple rudimentary screening tests. It has to be a fairly involved neurocognitive evaluation, a structured evaluation that can last 3 to 4 hours. And during that time, your brain gets taken out for a test drive. You basically get pushed to your limits in terms of different aspects of your memory, your visual memory, your verbal memory, your working memory, your language skills, your executive function skills, your visual spatial skills, your attention span, your motivation. So we check all these different areas, and then we weave a map of your cognitive function, and we look at it and we say, what does this pattern look like? And I have to tell you, the pattern of cognitive loss that you see in perimenopause, where patients have trouble with learning lists and their auditory memory, and they have trouble with coming up with words, word finding problems, and they may have some multitasking executive function deficits. That's all similar to what we would see in very, very early Alzheimer's. So if you are not aware that this can occur in perimenopause and menopause, patients can be misdiagnosed. And I've seen this in my practice. I've seen women who've been misdiagnosed, including my very first patient that I was guilty of misdiagnosing because I didn't know that these kinds of changes can occur in perimenopause and menopause. And again, perimenopause is a period of up to 7 years prior to actual menopause, not have had it for a year. and then you're officially in menopause.
Knowing that brain fog is a common symptom that many women experience when they're going through perimenopause and menopause can be comforting. It can also lead someone to wonder how experts distinguish between cognitive changes caused by menopause versus other factors. And what cognitive changes should we be looking out for?
The brain has this process called learned non-use, which our grandmothers used to say, if you don't use it, you lose it. So learned non-use is where brain will no longer continue to access an area that's becoming more difficult. So what I've found is in women who have trouble, say, finding words and they have an extensive vocabulary, they have a great verbal lexicon to draw from, what ends up happening is that they start to use simpler words and they're okay with the simpler words. And after a while, you get used to using the simpler words. So for some people, accommodate the change in function and they're fine with it. A few people actually are able to go back to prior level of functioning. And some people don't accommodate and continue to feel the effects of this reduced functioning. And they're the ones I see in my office. I had put together some criteria for what I call menopause related cognitive impairment, acronym MERCI, MERCI, and published this in the Journal of the American College of Obstetrics and Gynecology. And basically, what we want to say is that the person has a subjective change in their thinking. They have a sense that their thinking has changed, that it's persistent and over for at least 12 months. And it's not related to other factors. There are multiple other factors, as you mentioned, that could cause cognitive impairment, including, as we discussed earlier, lack of sleep, et cetera, but also things like thyroid dysfunction, depression, et cetera. And so you want to make sure that there's nothing like that. You don't necessarily have to have laboratory evidence of low estrogen, because the best indication that you're in perimenopause is a change in your period in terms of the duration of the period, in terms of the quality of the menses, the amount of fluid, et cetera. So it doesn't have to be that you have to have low estrogen levels in the blood. And then you have to have objective evidence on testing of at least 1 to 2 cognitive areas where there's a difference from what we think of as your baseline. And there's no evidence of, as we mentioned, other medical conditions. So that would then be the criteria for menopause-related cognitive impairment. And I also wanted to quickly mention, because I just love this, that even though, as you say, we need to raise awareness, back in 1871, when medicine was still in many ways not as evidence-based, an English physician called Tilt described the changes in 500 menopausal women. And I'm going to read some of the things he said back in 1871. It's a shame that 150 years later, we're still trying to let women know that this could happen to you. So he was writing in 1871 and he said, there's almost always a partial paralysis of cerebral power. He wrote that women lose confidence in themselves. They're unable to manage domestic or other business. They have a feeling as if a cloud or a cobweb is required to be brushed from the brain. And that's something I've often heard. Women will say to me, it feels like I have a cloud. It feels like there's a web. And then he also writes, women forget where they put their purse. Sometimes they forget their way home. 1871, 500 menopausal women. And how come all these years later, we're still trying to make it happen? We're still trying to let women know. So I think it's sad, but hopefully within the next few years, it'll become more common knowledge.
Sharing personal experiences with menopause can be crucial for many reasons. First, fosters a sense of community among women, offering support and understanding by letting them know they're not alone in their journey. Openly discussing perimenopause and menopause breaks down the walls of silence and stigma that can lead to myths and misinformation surrounding this normal phase of life. But how do we build or find these communities? How do we start discussing something that's been taboo for so long? We discuss this with Kruti and Falguni of Getting Hotter, a platform dedicated to sharing experiences, information, and resources for anyone navigating perimenopause and menopause.
We felt like there was a void there There is medical literature, which was varying degrees of antiquated, and everything kind of made us feel old. And here we were, two women who had young children, and we were handed books and literature that made us feel like we were 1,000 years old. The language was oriented towards end of life, end of your sexuality, end of your vibrancy. So all of the negative connotations around it were stupefying. And then we just thought, why is this a portal down to the depths of despair? There has to be a way that we can reframe this conversation in a way that's meaningful and that's positive focus, because I experienced menopause at 45, and it's not unreasonable to expect that I'm going to be living another 40 years. So we're talking about things ending, and we're talking about the end of your womanhood, but you still have half of your life to live. What we are trying to do, we're humbly trying to do, is to create a space where we can have a colloquial conversation about it, about all the things that are related to midlife and wellness. We don't go through menopause and perimenopause in vacuums. We don't go off into our little corners and have our hot flashes, and it doesn't affect anybody and it doesn't matter to anybody. And we have family, we have friends, we have work, and we need to be able to have a conversation, and we need an open space to be able to do that.
One of our approaches, we both realized this as we would talk about it, is a little bit of humor in our storytelling around it, because I think that there's so much doom and gloom around this. And truly, there are amazing moments happening in our lives at this stage. And we both happen to, I think, hit menopause early, 45 for me as well. When we try to talk about this and when it feels too dark, I think people turn away. And the truth is that, yeah, these are symptoms and they vary from person to person. But we wanted to create a space where people feel like they can come and discuss whatever aspect of it is bothering them, whether it's vaginal dryness or I am not in the mood to do anything right now. Like, is this going to change at any point?
There's a lot of fear around it because of all those cultural connotations of menopause. You're not a vibrant woman anymore. You're not a viable asset in the workplace. You're not a sexual being anymore.
We barely talk about periods, right? So let alone when you've stopped having your period and what all of that means. And also, like, our symptoms aren't the same. Well, there's all this information out there about vaginal dryness. I'm like, actually, like, can I focus on my anxiety more? Because I'm having more anxiety than I am vaginal dryness. Like, I don't need the rejuvenation right now. What I need is help getting through this anxiety that I feel.
I also think that's why having conversations is important, because it's not a situation where you can say, oh, well, this is happening. Well, you take this pill and then that's going to happen anymore, right? It's almost like the solution or the medicine is the conversation in a way, because it's not going to go away. It's not going to go away anytime soon. It's going to keep evolving, keep changing. And the kind of assistance that would be beneficial to each of us is going to be different at various times. And the only way to really start to understand it, start to build a framework around it, and start to build a raft of support around it is to have a continued conversation.
As a storyteller, I've never seen a more poignant time where storytelling is so important, because if we don't share these experiences, if we don't share with each other, then other people who are sitting quietly can't process actually what's happening. I was reflecting on it as she was talking. It's like every phase of whatever I may be going through, we'll text each other. I was like, oh, I went on the patch finally, or whatever it was. And she's like, really? And we can have these conversations that it feels so good, actually, to be able to openly talk about this in a way that's honestly just normal. It's like we're just talking.
Yeah. And I think that reaching out to people for help, reaching out to resources, there's no start line, there's no finish line. This is the rest of your life. And it's about allowing yourself the time and the space to understand that there is uncertainty, that there is a lot of unknown, and that's okay, because everybody's going to go through this at some point and in some way or another. No one should feel intrinsically alone. If I were to say what is the most sort of salient call to action, is to just spend some time every day in this experience, and also telling yourself the narrative, there's somebody else that's going through this exact same thing.
It's a season in your life, and there's nothing to be shameful about in this season, because there's so many other wonderful things that are probably also going on at the same time.
Perimenopause and menopause, like all changes in our health, need a wraparound approach to care. The goal should be to create an environment where women feel both comfortable and informed about what they'll encounter during these life stages. This includes addressing not only physical symptoms, but also mental and emotional changes. We can achieve this by fostering ongoing, honest conversations and being open to sharing our experiences. The more conversations we have, the less room there is for shame, stigma, and misinformation. Thank you for listening. Please take a moment to follow, rate, and review this podcast on your favorite listening platform. If you'd like to send me an email about topics you're interested in or questions for future guests, please send me a note at webmdpodcast@webmd.net. This is Dr. Neha Pathak for the WebMD Health Discovered podcast.